Beside pain, probably the most distressing symptom that we see here at the Hauser Neck Center is gaze instability. So you don't realize we have two eyes and they have to see the same thing. And because we have two eyes, we can see in 3 dimensions. So imagine if the perception of something was different in the right eye than the left eye, and you had what's termed gaze instability. So you were either blurry, there's 2 of you, or you're moving though you're not moving. Because I'm sure you've heard from patients, you know, when I get in a car, I'm terrible.
Yeah.
Because you don't realize, like, you don't realize how coordinated your vision and your brain has to be to not be seasick when you're riding in a car. So, and then it starts with you ride in a car and you get that seasickness feeling, but eventually, because all these disorders are progressive, you'll end up having it when you're just sitting still. So imagine 24 hours a day you feel seasick.
That's awful.
Or you can't see clearly. You know, so yesterday I had a patient who, Doc, I'm just telling you, my vision, instead of being here, it's like here.
Wow.
And then within the last week, I saw somebody with terrible visual snow. Like the whole, when they look, it's like there's snow all over the place. Like staticky, maybe a TV was static. Because it's common, somebody has terrible vision, which is gaze instability, blurry vision, double vision, spots, the image isn't clear, and they go see several ophthalmologists, even neuro-ophthalmologists, and they'll say that the eye is fine. So how could the eyeball itself be fine? The retina's fine, the lens is fine. There's no loose bodies or whatever in the fluid, but yet their vision is blurry.
Well, that's exactly it. Their eye is fine. You know, they've ruled that out, essentially going to see the specialist, but the basically electric activity that is putting what you're seeing to like an actual image in your brain, the cable, so to speak, that's what's actually disruptive. It's not the eye, it's the cable. After Hurricane Ian, a lot of people didn't have power. It didn't mean that their TVs all of a sudden broke and they weren't working. Their TVs were fine. It's the actual electrical input to make it work. That's what was disrupted.
Yeah, even in our rental house, it's still actually not fixed. Like the internet is so slow. So Comcast came out, you know, they fixed some things, you know, because the hurricane, man, the cables underneath had to be changed, the boxes, you know, everything. So the nerve that takes the image from the retina to the brain, that's called the optic nerve. So it's this optic nerve, see that, the optic nerve.
Yep.
So you don't see till the electrical current gets interpreted by the brain, and then you actually see. And then the image from your right optic nerve and your left optic nerve has to be the same.
Right.
So just about like an hour ago, my last patient that I was seeing, I was showing her that on the MRI, the ventricles were much bigger on the left side than the right side. So she was having a blockage of the jugular veins on this side. So because of that, her fluid around her left eye nerve was greater than her right eye nerve. So obviously if you have pressure, more pressure from fluid on your left eye nerve than your right, then the image is going to go slightly slower on to the brain from the left eye nerve. So thus the brain actually sees 2 of you, 3 of you blurry because the electrical cable's all screwed up. And then I put this in here just to show that there are other things beside the eye nerve that's involved. The superior cervical sympathetic ganglion, that's what causes your eye to dilate. A lot of our patients, they have light sensitivity.
Yes.
We do pupillometer, you know, we have a pupillometer, and that shows that almost all the patients that come into the Hauser Neck Center that you see and I see, they have pupil dilation, so that's what gives the light sensitivity. And then when your pupils are dilated all the time, it increases your intraocular pressure. And then we, of course, measure intraocular pressure. Now, what's not known to a lot of people is that ganglion sits right at C2. So obviously we see a lot of C1, C2, C2, C3 instability, so that can just irritate that ganglion.
If you've ever gone to the optometrist and they have to dilate your eyes, well, it takes a while, right, for that dilation to kind of run its course. So when you leave, they usually give you sunglasses, or you have to bring them because all the light is just like coming in your eye until your pupils are no longer dilated and they go back to normal size. So some people with this condition, like that's their new normal. It's not normal, but that's how they live. Like every day is just getting all this influx of light, and they're so sensitive to it, as we all would be.
Yeah, a lot of people don't realize light sensitivity can be coming from upper cervical instability, which we'll talk about. Now, I alluded to that there could be fluid around the eye nerve. So we're going to talk mainly on jugular vein compression causing the fluid to build up. But it can build up from other causes, right? Like you could have CSF block.
Yep. So if we look here at this cross-section image, this is the vertebrae here, and then right in this tunnel is your spinal cord, and that white is all of that CSF flowing around it, and you can see that white travels around all the sides of the spinal cord.
Yep.
Whereas in here, you can see that the spinal cord has lost that CSF flow here. It's only white above here, and instead it's touching actually on the vertebrae, which is not supposed to do.
So anybody who has their MRI at home, you could actually see this, that the CSF could be getting blocked there. And sometimes the solution is simple. For instance, sometimes it's just due to the cervical curve being abnormal. So just a simple x-ray can diagnose that. Now, the most common cause of fluid going around the eye nerve is going to be jugular vein compression. So how can jugular vein compression cause all these symptoms, depersonalization and all these things?
Well, if we look here, this is a model of the neck. So in the front of the neck, you've got your jugular veins, these blue cords, one on each side. So if this vein is compressed, think like kinking a hose, what happens is all the fluid builds up in the brain. And then your body doesn't want that, obviously, and so it tries to find ways to kind of diffuse that pressure and leak that fluid out. And one, or I should say two of the places it will do that are the optic nerves, on each side. So by actually looking to see if that optic nerve is swollen, you can determine if that jugular vein is compressed. But again, if you have all of that buildup of pressure that's not cycling in and out of your brain like it should, that can actually contribute to this head pressure. Makes sense, all that extra pressure in your skull can make you feel dizzy. And then as it relates to the optic nerves, that's how you can get that visual snow like we talked about, distorted vision, after images.
After image would be that I look at you, now I look away, and then you're still there. So you could say, well, geez, how could that be? So think of it this way. So I have the case I said where there's a lot of fluid around the left eye nerve. So I'm looking at you, and the image of you through the right optic nerve I see. So I see you, then I look away. Now my brain gets the image from the left eye nerve. And that's where I think that's the explanation of the after images. I'm not saying that's the only cause of after images, but that's the most common cause that we see. We were just playing around with like a balloon. This is actually a balloon, I think, that Izzy blew up, but basically when the balloon was 9 inches, 9 inches, then we stretch it to 11 inches, because in other words, when you go like this, you're stretching it, so you're stretching the jugular vein. The jugular vein has no muscular wall. Like if you ever watch MMA fighting, they got a person in a headlock and they don't faint because the artery, it has a muscular wall. So the person's going, and the person still doesn't faint. It's unbelievable the force the artery can handle. But the jugular vein, you just go like this, boom, right under. It takes almost no force to block the jugular vein, and that's why the bad posture with the cell phones looking down and the computers, it's so destructive to the brain because it blocks the venous flow, and 70% of the fluid in the brain is in the venous system. And the first part of the venous system draining the brain is right at C1. So that's atlas instability is the number one cause that we see for blockage of the jugular vein. And we just call it a clogged brain toilet. Why do we call it a clogged brain toilet?
Well, because you came up with that. Yeah. But really, basically the plumbing is off. Like you can't drain. Like what should happen is you have the flow in and out. It kind of provides fluid and nutrition and then removes all the debris. But if you don't have a way to kind of remove all of those waste products because that is kinked or constricted, it's just going to keep building up and building up, and all that debris is going to sit there.
Yeah, no, exactly. And then when you have increased brain pressure, you can actually squish the back of the eye. So that's one of the causes of high eye pressure. If somebody's out there who, like, they could be a health person, like they take care of themselves, but their eye pressures are crazy. It could be that your high eye pressure is from high brain pressure. The other thing too is the fluid builds up on the outside of the brain typically. So this is the frontal cortex or prefrontal cortex, which is where you get higher cognitive functioning. So a common symptom of jugular vein compression is just brain fatigue or brain fog, or doc, I feel like I'm getting Alzheimer's, or my memory, even short-term memory, can start to be affected. So anybody who's having personality changes or intelligence is tanking, or they just can't do their job anymore, they should think about, well, maybe I have cervical instability that's blocking the jugular vein, causing increased intracranial pressure. What would be some signs or symptoms, other symptoms that might give them a clue that it's actually a cervical instability problem?
Yeah, I mean, the obvious one is neck pain, or even just kind of a neck tightness, muscle tightness in that upper area, kind of right at the base of the skull. Some people also will get headaches. We talked about dizziness, lightheadedness, clicking, popping, cracking in their neck, even with just simple movements that happens over and over again. Or even patients that they'll say, gosh, I just feel like I have to click it, and then I kind of, everything releases for a little bit, but then it just happens day in and day out.
Right. Yeah, that's exactly right. Now in the office, so we talked a lot about fluid around the eye nerve.
Yeah.
So how do you check it?
Yeah, so this is right here, the patient's eyeball, essentially, and then there's the optic nerve right here that feeds the back of the eye. So we measure that, and if it is swollen, you would obviously get a bigger measurement.
Sometimes we do in-house data. So I think this was from last year. We did 138 consecutive patients, that we had seen together. Normal optic nerve sheath diameter is, depending on the study, some studies show as low as like 4.5, some studies, in the upper 5s. I just put on here ideal. The average in the 138 patients that we saw was 5.8, and 26% of people had extreme. And then this just shows kind of the difference. This one's like almost twice the size of that one. And then there's different ways to see jugular vein compression.
Yeah, so these are ultrasound images. This is a wide open, big patent jugular vein. And then you can see here how it's just kind of more squished. So this right here, you can see the carotid artery always stays like a nice circle. Always in all of them. And that is because, like you mentioned, it has a muscular wall. So it has this protective barrier almost, so to speak, to keep it open so you can keep blood flow going. But this jugular vein doesn't have that muscular wall, and so much easily can be compressed.
One of the common questions we'll get is, well, how come like I have a good day where my vision isn't so bad and other days it's terrible? So how would you explain that?
Yeah, so again, because this jugular vein sits right in front of your upper cervical vertebrae. Really, like if you have days where maybe you've been on your phone more and you've had this kind of more forward head posture and those vertebrae have slipped forward, a couple millimeters or whatnot, that could be the difference between you having a good day and you not.
Yeah, no, it's kind of correlates with this. And then once we get their neck structure better, so we call what we do neck reconstruction therapy, but we do it without surgery. So we do various exercise, weights, proper positioning of the computer station, prism glasses so you can look at your cell phone. And then obviously if there's instability, we do prolotherapy. It's normal though for the jugular veins to be more closed when somebody's upright. So if they have a terrible neck structure and the neck structure is already blocking it, it's not uncommon for us to see people where the jugular vein is 100% closed, when they're upright. So in those situations, we normally recommend, well, we basically do a bunch of tests to figure out what sleeping position is best for them. So anybody at home who's having a terrible time, what you might do is change your sleeping position and then try not to rotate your head. So some people, as you know, Danielle, they have these styloids that block the jugular vein. So the styloids, those are going to block the jugular veins when you rotate. So you lay on your side, then you look up at the back wall, don't rotate your head, and then just sleep in that position. Or at minimum during the day, 5 minutes every hour, just be in that position, like lay down. And you might find that, oh my gosh, my head pressure's better, my vision's better.
Especially people that say like they wake up and they feel terrible. You know, when you first wake up in the morning, for the most part, should really be when you feel the best. You've been laying down, you've been resting, you haven't put any stress on your joints for however many hours. Like, you should wake up feeling pretty good. But if you wake up, you're like, I feel terrible, I have a terrible headache, I have all this brain pressure. When I wake up, it quite possibly could be that just your sleeping position, by no fault of your own, is compressing your jugular veins, and it just needs to be modified to allow for better blood flow.
Yeah. And then, you know, occasionally we'll do venograms, right? So what does this show?
Yeah, so this is a CT venogram. So you can see here the vertebrae right in through here. And then this, your jugular vein is really not as open and patent as it should be. It's getting compressed between your vertebrae and your styloid.
Yep, so this kind of just shows it, like, see how big the jugular vein is, but real narrowed there.
And like here, like kind of bulbous, and then there's, it's getting kinked.
Yeah, and then there, right there, it's flat.
See how open it is on this side, and then right here it's kind of coming like a pancake.
What would you recommend for somebody with really bad vision? What should they consider doing to see if it's a cervical instability case?
In our office, we do a lot of testing, including a digital motion x-ray, which is an x-ray movie where you're actually moving your head in certain positions, and we'll see if your neck vertebrae are moving more than they should. They're shifting too far forward or to the side. And then also looking at the neck curve. If your neck curve is serpent-like or even a reverse curve, that also needs to be addressed, because that will put tension on your jugular vein as well.
Yeah, and then like we had said, we do various eye tests. We check the pupil diameter, pupillometer. We do tonometry, which is eye pressure. Then we do optic nerve sheath diameter. And the wonderful thing is we can do them over time. So we might do them every 2 or 3 or 4 months, you know, depending on how often they get prolotherapy. And typically it gradually improves. You know, it doesn't always improve, but most of the time it improves. And then, you know, with that comes, of course, their vision gets better, and that really is life altering for the people.
Yeah.